First, we will talk about fatty infiltration of liver. Most patients with a fatty liver are asymptomatic. The fatty infiltration may be diffuse or focal, and focal lesions may be solitary or multiple. On the left side is the normal liver, and the right side is the fatty infiltration liver. We can see the hypotenuse area of the liver, fatty infiltrated area. We can see it's multiple lesions. The hallmark sign of fatty infiltration is the blood vessels stand out prominently on non-contrast CT scans. We can see these three images are non-contrast CT scans, but we can see the blood vessels stand out, and also these vessels are neither obstructed nor displaced. When there is fatty infiltration, we can see the spleen. Here is the spleen. The spleen is denser than liver without intravenous contrast, but in normal people, the liver is usually denser than spleen. Here is also a non-contrast CT scan. The spleen is denser than the liver, and also we can see the vessels. Here are the vessels. The vessels stand out in the fatty liver. What we should pay attention is that focal fatty infiltration can produce an appearance that mimics tumor, but fatty infiltration usually produces no mass effect, and it has the ability to appear and disappear in a matter of weeks, quite unlike tumor masses. MRI is very useful in diagnosing fatty infiltration of the liver. It uses a phenomenon called chemical shift imaging to detect the presence of microscopic intracellular lipid present in the fatty liver. And in image A, we can see the liver appears normal and brighter than the spleen, but in image B, we call it opposite phase image. Here is the opposite phase image, and it demonstrates marked signal loss throughout the liver, indicating a fatty liver. Most of the liver is now darker than the spleen, except for the caudate lobe. The caudate lobe is still normal, but here is the caudate lobe. It's still normal, but most areas of the other lobe, including left lobe and right lobe, we can see a marked signal loss. Hepatic cirrhosis is a chronic irreversible disease of the liver, which features destruction of normal liver cells and diffuse fibrosis. Cirrhosis features destruction of normal liver cells and diffuse fibrosis. Cirrhosis appears to be the final common pathway of many abnormalities, including hepatitis B and C, alcoholism, non-alcoholic fatty infiltration, and miscellaneous diseases like hemochromatosis and Wilson disease. Complications of cirrhosis include portal hypertension, ascites, renal dysfunction, hepatocellular carcinoma, hepatic failure, and death. In hepatic cirrhosis, we can see nodular regeneration of the liver results in nodular health of the liver and in homogeneity of the parenchyma. An MRI is the most sensitive imaging modality for examination of the liver in cirrhosis and other diffuse disease of liver. An ultrasound is the most frequently used diagnostic imaging modality. In patients with cirrhosis, the liver parenchyma is coarsened in its echogenic pattern, and surface nodulity is well seen in the presence of ascites. Here we can see the surface nodulity in ultrasound images, and sometimes we also can see gallstones in 33 to 46% of patients with cirrhosis. CT is useful in demonstrating the morphologic evidence of cirrhosis within the liver, and early in the disease, the liver may demonstrate diffuse fatty infiltration. As the disease progresses, the liver contour becomes lobulated. The contour of the liver becomes lobulated, and we can see the irregular of external contour of the left lobe. With progression, the morphologic changes are common. The liver shrinks in volume with the right lobe. We can see the right lobe of the liver is shrinking, and while the caudate lobe and also the left lobe become disproportionately larger, especially in alcoholic cirrhosis. In this case, we can see the nodularity. Here we can see the nodularity of the liver contour and atrophy of the right lobe and enlargement of the left lobe. And there is also a mottled inhomogeneous appearance to the liver parenchyma. We can see mottled inhomogeneous appearance of the liver parenchyma following intravenous contrast enhancement due to a mixture of regenerating nodules, focal fatty infiltration, and fibrosis. Portal hypertension may develop, which can lead to dilated vessels around the stomach. Here are the dilated vessels around the stomach, and also around the splenic hilum, and also esophagus, representing varices, and splenomegaly may also develop, and ascites may be present. This CT image is a portovenous face CT, and is a typical example of advanced hepatic cirrhosis. And we also can see the liver is atrophic and irregular in external contour. This is also a typical case of cirrhosis. We can see the atrophy of the right lobe and enlargement of the caudate lobe, and also we can see the dilated vessels around the stomach, and also hepatic hilar, which representing varices, and also we can see its splenomegaly. And these are hallmark signs of hepatic cirrhosis. In this case, we can see numerous collaterals within omentum. We can see collaterals within omentum, and also superficial vessels. These are superficial vessels, anastomosis with para-umbilical vessel, and also we can see very large varix in the umbilical region. In this case, we can see the development of extensive collateral vessels and lower esophagus. Here are the lower esophagus. We can see collateral vessels, and also we can see ascites and splenomegaly, and varices are adjacent to and within esophageal wall. Sometimes it can be difficult to differentiate between ascites and pleural effusion on CT examinations. Patients may have the combination of ascites and pleural effusions for a number of reasons, cirrhosis being one of them. Usually, ascitic fluid will appear anterior to the hemidiaphragm. Here is the hemidiaphragm, and ascitic fluid usually located anterior to the hemidiaphragm in the atrial gram, and pleural effusion will be located posterior to the hemidiaphragm. And ascites will never completely encircle the liver because of the bare area. Here is the bare area. It's not covered by peritoneum, so fluid posterior to the bare area must be in the pleural space. MRI offers an alternative non-invasive method to image the liver. In MRI image, we can also see the nodularity. We can see the nodularity of the liver parenchyma, and also the atrophy of the right lobe, and the splenomegaly of the spleen, and also ascites, and also the dilated vessels. Next, we will talk about the space occupying lesions of the liver. One of the primary aims of imaging studies, no matter what part of the body is being studied, is to accurately differentiate between benign and malignant processes using techniques that do not place the patients in danger or subject the patients to unnecessary pain. This is the central goal in evaluating liver masses as well. And CT studies are best at demonstrating liver masses when performed both with and without contrast. And MRI is useful in characterizing liver masses, particularly small lesions. First, we will talk about metastases. Metastases are the most common malignant hepatic masses, which most are multiple, and also represent the most common cause of a solitary malignant mass in the liver. Most liver metastases originate in the gastrointestinal tract, particularly the colon, and almost all reach the liver via the bloodstream. Other primary sites of metastatic spread to the liver include stomach, pancreas, esophagus, lung, melanoma, and breast. Metastases are usually multiple low attenuation masses. We can see they are low attenuation masses, and usually they are multiple. We can see numerous low attenuation masses in this case. Major metastases may demonstrate areas of necrosis. Here we can see the areas of necrosis that can be recognized as multiple area of low attenuation within the mass. Here is the necrosis area of the metastasis. This is an example of MRI images of metastasis. MRI is as sensitive as CT in detecting liver metastasis, but is usually used in the problem-solving role. Metastases usually appear as multiple low attenuation masses. In this case, we can also see these low attenuation masses located in the spleen, and this patient had a primary adenocarcinoma of the colon and metastasis located both in liver and spleen. The second disease is the hepatocellular carcinoma, named HCC. HCC is the most common primary malignancy of the liver. It's the most common primary. Metastasis is the secondary malignancy, and HCC is the primary malignancy of the liver. Usually, HCC will arise in livers with pre-existing abnormalities such as cirrhosis or hepatitis. Most HCC develop by means of the multi-step regression from a low-grade dysplastic nodule to a high-grade dysplastic nodule to a dysplastic nodule with the focus of HCC, and finally to overt carcinoma. AFP is an HCC tumor marker. Values more than 100 nanogram per milliliter are highly suggestive of HCC. Evaluation can be seen in more than 70% patients. The sensitivity of ultrasound for HCC is about 75%, and they are usually heterogeneous and also hypervascular. Most HCC are solitary, but up to 1 out of 5 can be multiple. There are 3 morphological forms of HCC. One is large multiple nodules. The second is solitary mass, but smaller than 3 centimeters, and the third is the diffuse infiltration. In image C, we can see diffuse HCC located both the right lobe, left lobe, and also caudal lobe of your liver. Here is an example of diffuse hepatocellular carcinoma of the liver. Image A and image B are both CT images. In image A, we can see a typical low attenuation lesion. Here is the low attenuation lesion is seen in the right lobe of the liver on the non-enhanced scan. We can see there is no contrast material inside the artery, so this is a non-enhanced scan. And in the arterial phase, of the image B, we can see patchy enhancement indicating probability of tumor necrosis. These areas may be tumor necrosis in the low attenuation areas, and also this area. And these areas are patchy enhancement. And also there is ascites present. And the overall volume of the liver is decreased, and the contour, you can see the contour is lobulated from underlying cirrhosis. On CT, most HCC are low density or the same density as normal liver, without contrast, enhanced on the arterial phase with full contrast, usually hyperdense, and then return to hypodense or isodense on the venous phase. Here is a typical example of HCC is isodense on enhanced images and hypodense in arterial phase and hypodense in venous phase. So we can see an enhancement of the HCC in the arterial phase, and also a wash-out phenomenon of the HCC in venous phase, and also wash-out in delayed phase. Sometimes we can see the tumor capture on the delayed phase. We can see here is the tumor capture. Here is the tumor capture, and also we can see low attenuation areas, low necrosis, and sometimes we can see the calcification. And besides the necrosis, sometimes we can also see the satellite lesions. Here are 2 satellite lesions. In advanced HCC, there is an important sign named portal vein thrombosis. In this case, we can see multiple hypodense nodules. We can see the nodules located in the right lobe of the liver. Here, all of this part are HCC, and we can see this is the filling defect within the vein. This is called portal vein thrombosis. This is a hallmark sign for advanced HCC. HCC can be hyper or iso or hypo on T1 images of MRI, but it always hyper-intense on T2 images. And the tumor capsule is hypo-intense on both T1 and T2 images in most cases. Sometimes we can see focal fat inside HCC. In this case, we can see the 3 most important hallmark signs of HCC in MRI images. They are hyperintense on T2 images, and the contrast enhancement. After contrast enhancement, we can see the wash-out phenomenon, and also we can see the tumor capsule in the delayed phase. In this case, we can also see the specific signs of HCC. We can see they are hyper-intense on T2 images, and it's hyper-intense in arterial phase images, and then hyper-intense in venous phases, and this phenomenon is called wash-out phenomenon. And also we can see here, we can see the tumor capsule. These are the hallmark signs of the HCC. The third disease is the hepatic cavernous hematoma. It's the commonest primary benign liver tumor. Both metastasis and HCC, they are malignant tumor, but hepatic cavernous hematoma is benign liver tumor, and it's the commonest primary benign liver tumor. They are more common in women and usually asymptomatic. In ultrasound, hepatic hemangiomas are well-defined, uniformly hyperechoic liver mass with peripheral feeder vessels that are characteristic of the hemangioma. We can see they are hyperechoic. In enhanced CT, hepatic hemangiomas usually hypodense lesions, and the attenuation value of the hepatic hemangiomas is very similar to that of blood in the inferior vena cava. Hepatic hemangiomas has characteristic nodular enhancement pattern. We can see peripheral nodular and discontinuous enhancement in the arterial phase, and then progressive centripetal filling. It means an inward enhancement. Here is a case of hepatic hemangioma. We can see a hypodense tumor located in the left lobe of the liver, and in arterial phase we can see nodular enhancement in the peripheral area of the tumor, and then the enhancement is inward, filling in the central part of the tumor, and it can appear denser than the rest of the liver on delayed scans. And this typical contrast enhanced type is very useful for diagnosis of hepatic hemangiomas, and we can see the enhancement is from peripheral to center. Here is an example of cavernous hemangioma of the liver, and the three images is a triple phase CT study. In image A, we can see a cavernous hemangioma, hypodense lesion. We can see it's a hypodense lesion on unenhanced scans. They characteristically enhanced from the periphery and inward, following injection of intravenous contrast during the arterial phase and eventually become isodense. Contrast then tends to be retained within the numerous vascular spaces of the lesion so that it characteristically appears denser. This mass is denser than the rest of the liver on delayed scans. Here is also a typical case of hemangioma. We can see in arterial phase, we can see multiple areas of globular peripheral enhancement. Note that the enhanced portion of the mass have an attenuation value similar to that of the intrahepatic vessels. In equilibrium phase, we can see near complete enhancement of the mass with an attenuation value equivalent to that of blood in the inferior vena cava and hepatic veins. When we talk about SCC, we said it's always hyperintense on T2 images, but hepatic hemangiomas, they are usually marked hyperintensity on T2 images. And the enhancement pattern of the MRI is the same as seen at CT. Let's see an example is hyperintensity on T1 images and marked hyperintensity on T2 images, and also an inward enhancement pattern. This is another example of hemangioma. We can see marked hyperintensity on T2 images and also nodular peripheral enhancement on artery phase, and then flush inward, and then nearly the whole tumor enhancement, named inward contrast phenomenon. MRI images of cavernous hemangioma of the liver. In image A, it's an actual T1 weighted image, demonstrate a well-circumscribed, slightly lobular dark mass in the right hepatic lobe. And subsequent images following the administration of intravenous contrast show peripheral to central enhancement until the entire mass homogeneously enhanced on a delayed 10-minute image. The combination of this enhancement pattern and the signal characteristic of the lesion allows an unequivocal diagnosis of hemangioma. The first disease is the hepatic cyst. Hepatic cysts believed to be congenital in origin, especially identified as sharply marginated. We can see the margin, how sharp, and spherical regions of low attenuation, usually fluid density compared to the remainder of the liver, and they are usually non-enhanced. This image is the CT scans of hepatic cysts. Hepatic cysts believed to be congenital in origin. Hepatic cysts are easily identified as sharply marginated spherical regions of low attenuation. Usually they are fluid density, about 0 to 20 HU, and compared to the remainder of the liver on both unenhanced and enhanced scans, they are homogeneous in density. MRI is much better than CT at characterizing cysts. They are also marked hyperintensity on T2 images, but they are unenhanced, unlike hemangiomas. They are usually solitary and homogeneous in density. Then we will talk about biliary system. In these two patients, in patient A, thickening of gallbladder wall, the wall should be 3 millimeters or less. This wall is markedly thickened at 6 millimeters. And in patient B, there is an echo-free crescent surrounding a thickened gallbladder. Here is the area of echo-free crescent surrounding a thickened. This is the thickened gallbladder wall representing pericholecystic fluid. The patient had a positive sonography Murphy sign. MRCP is the non-invasive way to image the biliary tree without requiring injection of contrast material. MRCP is excellent at detecting disease of biliary or ductal structures, and MRCP has gradually replacing ERCP for diagnostic purpose. MRCP can show the pancreatic duct. Here is the pancreatic duct and also the common bile duct. And in this patient, we can see slight dilation of the common bile duct. And in this case, we can see stones was detected in the common bile duct by MRCP images. Here are the stones. They are located in the common bile duct. Here is also a case of stones located in the common bile duct, and we can also see the biliary ductal dilatation. And here is the stone. Because of the sign characteristic of bile, MRCP can be done without the need for the injection of contrast. In this case, we can see the enlargement of the common bile duct, and it indicates a colloidal cyst. It's a little difficult. In this case, we can see the enlargement of the common bile duct and also the duct inside the liver, and also concern for the malignancy of the pancreas. So we need additional parse sequence following the administration of gadolinium around better detection of the malignancy. In this case, we can see a small tumor. Here is the small tumor located in the common bile duct. Here is the tumor. The most commonly affected solid organs in front abdominal trauma are the spleen, liver, kidney, and urinary bladder. CT is the study of choice in abdominal trauma. Intravenous contrast is always used, but oral contrast is usually not administered. It is always best to contrast with the radiologist so as to tailor the best study to fit the patient's needs. In some emergency settings, a quick abdominal ultrasound is used in unstable trauma patients to evaluate for hemiperitoneal. These are 3 cases of splenic trauma. In case A, we can see subcapsular hematoma, and in case B, we can see splenic and also hepatic laceration, and also a large hepatic contusion, and there is also pneumoperitoneal. In patient C, we can see active extravasation of contrast-enhanced blood here, and it's still along with a large intrasplenic hematoma. Here is also an example of the splenic rupture with perisplenic hematoma. Here are 3 cases of hepatic trauma. In patient A, we can see subcapsular hematoma and also laceration. And in patient B, we can see multiple laceration of the right lobe of the liver. And in patient C, we can see active exacerbation of the contrast-enhanced blood from the large intrahepatic laceration with hematoma.